Hi, my name is Matt Rettig. I'm a genitourinary medical oncologist with a specific interest in prostate cancer. My research interests extend from the lab to the clinic and back. And I have been at UCLA and the affiliated VA for over 20 years. So the question is, how do I define non-metastatic castration-resistant prostate cancer? So first of all, let me say that there have been a number of randomized controlled trials that have asked the question whether or not a novel androgen receptor signaling inhibitor, such as one of the so-called lutamides, enzalutamide, apalutamide, darolutamide, improves outcomes for patients with non-metastatic castration-resistant prostate cancer. So in defining this entity, this state and stage of the disease, in these clinical trials, the staging was performed with conventional imaging. So for simplicity's sake, when thinking about a patient who may have non-metastatic castration-resistant prostate cancer and want to consider adding an agent such as one of the lutamides to the androgen deprivation therapy, I define it according to conventional imaging. However, we also use more sensitive PET imaging, and I'll talk about that in a second. So the definition would be a patient who has a rising PSA on androgen deprivation therapy, such as an LHRH analog like leuprolide, and has, of course, a castrate level of serum testosterone, 50 nanograms per deciliter or lower. The patient must also not have evidence of metastatic disease based on conventional imaging. Disease in the pelvis, including lymph nodes that are at or below the bifurcation of the common iliac artery, are not considered distant metastatic. And for the purposes of the definition of non-metastatic castration-resistant prostate cancer, would be included. And they were also included in the phase 3 studies that led to the regulatory approval of the various lutamides for non-metastatic castration-resistant prostate cancer. So very simply, 3 criteria. 1, castrate level of serum testosterone on an LHRH analog or having had surgical castration. 2, rising PSA. 3, no metastatic disease on conventional imaging. Now, what do we do about patients who have metastatic disease that's not detected on conventional imaging, but rather on more sensitive PET imaging? So, for example, the fluciclovine PET-CT scan or the PSMA PET scan can detect metastatic disease in the absence of metastasis detected on conventional imaging. And this is fairly frequent. So while we don't have the highest level of evidence on how to manage those patients, I should point out that these patients are often treated with metastasis-directed therapy. And there are a lot of clinical trials that have supported this approach. These studies are mostly phase 2 randomized controlled trials with ongoing phase 3 studies that are asking the question whether or not metastasis-directed radiation or surgery can improve overall survival. Treatment of metastasis, especially with modern radiation techniques, is very well tolerated. It's very uncommon to have a grade 3 or higher toxicity. So in my view, if one has access to a sensitive PET imaging modality, I would do it. For the purpose of deciding to add a therapy to androgen deprivation therapy, such as one of the lutamides, I would define non-metastatic disease based on conventional imaging and use the PET imaging to help guide us with respect to metastasis-directed therapy. That's how I approach the management of non-metastatic castration-resistant prostate cancer. And that's also how I define it, again, based on a castrate level of serum testosterone, a rising PSA, and no evidence of metastatic disease on conventional imaging.